Good afternoon. Thank you for inviting me to speak at the Association of Academic Physiatrists, a most prestigious platform, and it's an honour to be here. I must thank Dr. Amy West as well for her collaboration and presenting our work at AAPMR 2018. I'm sure she will revisit a lot of our important messages in her talk today. What I'd like to convey to you is how and why NeuroHAB evolved and how such a complex condition like back pain, which is of epidemic proportions, can be profoundly simple to cure. The most important message we wish to get across is an understanding of the rationale behind our program called NeuroHAB. How you deliver your NeuroHAB program is up to you, and it will be successful as long as the principles of the methodology are maintained. Amy said to me in her brief, make sure you explain how you do NeuroHAB, and I was thinking long and hard about this and finally realised that everybody is going to deliver NeuroHAB with their own style and flair, but underpinning that unique therapy provided, consistency must be maintained in how we affect our patient's central nervous system primarily, and then secondary to that, their musculoskeletal system, which is why the program is called NeuroHAB. Like many other processes, both biological and mechanical, they only seem complex when you don't understand the fundamental principles behind them. For example, the brain, in all its glory, is basically operating on sodium and potassium ions being pumped across a neuronal cell membrane to create an action potential, allowing nerve cells to propagate electrical impulses, creating productive circuitry and what we know as consciousness. And in non-biological systems too, we can marvel at what our machines do for us, but fundamentally they utilize simple nuts and bolts and physical principles that, once understood, solve what appear initially to be insurmountable challenges. Also think about conditions that are rare versus very common. Complex and infrequent events have to come together at the same time and place to form perfect storms, which thankfully are very uncommon. Back pain symptoms, on the other hand, are very common, epidemic in fact, and therefore undeniably must have a simple cause. No different to other disease epidemics like TB, malaria, HIV, smallpox, all of which are effectively managed by understanding and controlling the simple root cause. Ignorance of this concept is the likely cause of existing failing treatment paradigms and the reason why I coined the term and hashtag Failed RehabSyndrome. Back pain symptoms represent a condition that is being so poorly managed that the WHO considers it to be the leading cause of disability worldwide. It is one of the most significant economic health burdens for industrialised nations. The disability-adjusted life years have increased 54% in the last 25 years. Back pain symptoms are ubiquitous, and it remains clearly apparent that we are failing miserably to manage it. We must recognise this. If you don't adopt a paradigm shift in the way you manage back pain, you are failing to help your patients. We can't pass that responsibility on to our physical therapy colleagues, be they physiotherapists, exercise scientists, chiropractors, massage therapists, gym or PT instructors. They turn to us, the doctors, for guidance. The patients turn to us for guidance. We, as the patient's doctor, hold the bulk of responsibility and accountability for outcomes. Why did I develop NeuroHAB and functional movement therapy? Well, as a spinal surgeon, I would see 15 to 20 patients a day. On average, 1 in 30 patients would have a spinal structural problem amenable to surgery. The vast majority of patients are therefore suffering pain symptoms with no identifiable structural cause. That was my light bulb moment. If the patient's condition and symptoms were not secondary to a structural problem, it had to be a functional problem. Later on, I also realised that even the surgical patients who did have symptomatic structural compromise were also afflicted with a primary functional disease. They were just further along the functional disease spectrum with secondary symptoms from spinal instability or neural compression that required surgical correction. Therefore, 100% of patients with chronic back pain symptoms, whether requiring surgery or not, are suffering from a primary functional disease. So the back pain puzzle pieces are still a little bit scattered around this stage in 2014, 2015, but they're starting to take shape in the evolution of NeuroHAB. I had conceptualized back pain symptoms being secondary to a functional disease and eliminated terms like non-specific low back pain from my vocabulary. Sadly, it is still quite broadly used in peer-reviewed literature and the back pain therapeutic industry. It needs to stop. The next step and principle to conceptualize relates to defining the functional disease causing back pain symptoms. If we consider what the primary purpose of the musculoskeletal system is, we need to ask, why do we have bones, ligaments, tendons, muscles, and joints? I'm sure everyone will say and agree without conjecture that movement is the primary function of our musculoskeletal system. If you're a land organism without a musculoskeletal system, you aren't moving very much. The last time I saw a slug in the garden, it was still there the next day. So suddenly, another penny dropped when I realized that if the musculoskeletal system's function is movement, then a functional disease causing back pain symptoms must be movement dysfunction. So around 2014, 2015, I began asking my regular physiotherapists or exercise physiologists to treat my patient's disease of movement dysfunction. It was a dismal failure. Patients would be no better after frequent attendances with my industry-leading physical therapists, and understandably they would often be frustrated, angry and depressed because very often I was seen as the last hope and unfortunately the last referral in a line of many. And here I was explaining to them that their spine was structurally fine and all that had to be done was fix this condition called movement dysfunction and they would be cured. That was not the case in the early days. I then interrogated patients and my rehab providers with what treatments they were actually receiving. In every case, it was centered around couch-based recumbent therapy and all the usual manual therapy, soft tissue release, stretching, massage, but no upskilling of movement proficiency. At this point in my life, I was transitioning my sporting interest from similar gym-based core strength exercise and turning to Olympic weightlifting. I very quickly recognised that regardless of how fit, big and strong an individual was, it was not the discriminator of a successful, perfect, clean and jerk or snatch. The best Olympic weightlifters are those who are most coordinated and who have the least movement dysfunction for that task. I made the connection that if these compound movements allowed you to move very heavy objects very quickly, long distances, and make you look and feel great, why do we not integrate the same biomechanics in everyday life? So more light bulbs switched on in my brain, and I became obsessed with learning, defining, understanding, and teaching these movement points of performance for Olympic weightlifting and making them transferable to everyday life activities by creating reproducible, attainable guidelines that even my aging mum could adopt and apply to her life. The synthesis of my observations and research was that default proficient movement was characterized by these 5 very simple key movement principles. These form the cornerstone of our NeuroHAB program and underpin our success. If your NeuroHAB program is going to be successful, your patients have to become skillful and default with these movement points of performance. And it means that you need to apply a system or program that transfers these skills to your patients. Ours takes 16 hours delivered in 2 one-hour sessions per week with 90% practical focus and 10% education focus. Education in chronic back pain really means reversing years of misinformation. Misinformation like this recent patient in his mid-30s who was active and a high-level surfer who had experienced years of, at first, relapsing remitting low back pain, which was slowly becoming chronic. And he told us on day one, my back pain specialist physiotherapist, who I've been seeing for years, has told me I'm going too hard with my surfing for my bulging disc to handle, and my Pilates instructor told me I've got to strengthen my core, as he lifts up his shirt and shows us his six-pack. So much misinformation to delete from his brain. The next important principle relates to functional capacity and functional demand. And Amy will discuss this further, but in essence, chronic incompetence at expressing these NeuroHAB movement points of performance will unavoidably and progressively reduce functional capacity. And when it falls below the functional demands of a task or life in general, which represents the individual's injury threshold, pain symptoms and disability will occur. So we now have a new diagnosis that replaces terms like non-specific low back pain. It's a diagnosis of movement dysfunction causing back pain symptoms. Not one element of existing conventional rehab is upskilling movement based on NeuroHAB-defined movement proficiency. Patients may be getting stronger or marginally more mobile, but these quantitative structural focused attributes do nothing for the qualitative functional movement deficits driving their chronic back pain symptoms. Strength does not mandate movement skill. I have not referred a single patient to conventional passive rehabilitation or core strengthening exercise for about 4 years. Why was my previous physical therapist not able to deliver movement therapy like this? Awareness, education, knowledge, skill, all of the above most likely. The current economic business model and even the facilities for delivering mainstream passive and active physical therapy are not set up to deliver NeuroHAB. These are significant obstructions to the necessary paradigm shift that has to occur if we're going to beat the epidemic of back pain symptoms. Now, I am sure you're all familiar with the Oswestry Disability Score or Index. We collect this data on all our patients who are really the worst of the worst, chronic and centralised to varying degrees and biased to failure based on the fact that they are entering our program after being referred for a surgical opinion. Our patients are the ones who have not improved spontaneously with corner store Pilates, massage and deep tissue release. We generally won't see those acute or subacute patients until they eventually become chronic. When they do get to us, they are biased to failure. Our outcome data is unparalleled. We have treated over 600 patients since 2015 and collected prospective before and after ODI scores on 350 patients. Our average starting ODI score is 28%, indicating moderate to severe disability. And after 8 weeks of NeuroHAB, ODI scores better than halved with a 54% improvement observed. We have no exclusions other than MOBs, which stands for Movement Obstructing Barrier. If a patient has an MOB, it needs to be reversed in order to participate in movement therapy. MOBs are generally rare, but include things like structural deficits causing spinal instability, intolerable symptomatic neural compression, severe weakness, and intolerable pain, limiting even minimal proficiency limited range of motion. Our worst starting ODI of 80 finished at 44%, and our worst finishing ODI of 60 started at 74%. Our waiting list control group is unsurprisingly showing no significant variation from the mean starting ODI, given the chronicity of low back pain symptoms and exhausted primary failed rehabilitation. Let's start this video. I am constantly surprised by patients who cure their movement dysfunction and back pain symptoms when at first I think they have an MOB. I'm now offering NeuroHAB to patients that previously would have not been considered for conservative management, even those with neural compression. Rachel here in the video represented one of these patients who started the program so incapacitated that I didn't think she would improve, but incredibly with the progressive nature of NeuroHAB, she did improve steadily to eventually reach athletic status in 8 weeks. Simultaneously, have a look at this patient.
Carol was offered major spinal stabilisation surgery elsewhere for her chronic low back pain symptoms of greater than 10 years. She was referred to me for a further opinion, and given the significant focal structural breakdown at L2-3, I thought surgery would be a requirement in addition to NeuroHAB. We started the NeuroHAB program first in preparation for surgery, and I was amazed to observe that proficient movement therapy and her application of this into her activities of daily living reversed the disease of movement dysfunction and subsequently reversed her pain symptoms such that surgery was not required. Carol was offered...
Okay. Now, we do not cure the disease of movement dysfunction. We must make the patient accountable for their own recovery and make them realise that we, as doctors, will not cure their low back pain. There is no magic pill, injection, adjustment or surgery that can be offered. We can only provide them with a very simple but effective roadmap to recovery, but they must make the journey. And for some, it may be a long journey after 10 to 20 years of back pain symptoms with many speed bumps along the way. Having a roadmap, even if it is a long journey, is far superior than being lost with no guidance, going around in circles, which is exactly how many patients feel. Only they can upskill their body to fix itself once we eliminate the movement dysfunction, which limits their body's incredible spontaneous healing potential. Now, back pain is not cured at any functional movement training centre. We are only successful when our patients realise that getting out of bed proficiently is their rehab. Sitting, standing, bending forward to brush their teeth, stacking the dishwasher is their rehab. NeuroHAB gives patients the tools to make every second of every day rehabilitation, which becomes profoundly powerful and effective. My heart sinks when patients come in saying, "I've done my exercise for 30 minutes every morning, doctor, and I'm still not getting better." They have not been given the right message. How can 30 minutes of whatever exercise they've been given reverse 16 to 18 hours a day of poor movement, which drives inflammation and declining functional capacity over the preceding 10 years of course, that approach will fail. Implementation of movement therapy in NeuroHAB should not be delayed, and therefore engaging in therapies like conventional passive physical therapy or exercise, although not directly harmful, setting aside potential promotion of central sensitization, it does delay acquisition of skillful movement therapy, and therefore I consider it to be indirectly harmful. Functional capacity is the ultimate metric of health. A common treatment paradigm is to advise patients to reduce their functional demand in order to bring the system back into equilibrium. The treatment mantra actually promotes maladaptation. If it hurts, don't do it, or you can't continue to work in that career anymore. Without resolving the issue of why has my functional capacity declined leads to a never-ending cycle of increasing quality of life restrictions to keep functional demand in check, which ultimately will fail. We must build functional capacity on a foundation of movement proficiency. No MRI ever caused harm to a patient's spine. Misinterpretation and providing misinformation to a patient about MRI findings, on the other hand, is very harmful. There is a powerful movement from leading researchers sending messages to the health industry, the public and private health insurers, and the government discouraging imaging and surgery for low back pain. This reflects a deep ignorance of causation and also ignorance of the epidemiology of the condition of back pain. Now, virtuosity refers to relentlessness in coaching. We are not happy with near enough is good enough. In even the most simple hip hinge task, virtuous movement means being uncommonly exceptional at common, unexceptional tasks like sitting, standing, bending, squatting, which are the building blocks of activities of daily living, and more complex tasks that comprise what I referred to earlier as the sport of life. Drilling the 5 NeuroHAB movement points of performance allows the patient to produce central nervous system driven motor patterns that manifest in virtuous execution of these movement tasks, laying the foundation for the unavoidable improvement in functional capacity. Restoration of functional capacity is observable in this chronic pain patient after he learns how to move correctly. Default proficient movement is distinct from mandatory proficient movement, but you need to earn the privilege to move poorly and earn the capacity to control the spine in poor positions that breach the NeuroHAB movement guidelines. Our goal is the slow, steady and progressive modification of central nervous system motor patterns, hence the term NeuroHAB. It is no different to learning a new movement skill like piano or juggling. It is hard work and very demanding on both patient and movement therapist, especially in the early classes when pain levels are high and capacity is very low. I mentioned earlier that our NeuroHAB movement dysfunction program is 8 weeks and consists of 2 one-hour classes per week. We start with a simple assessment task that is repeated at the end of the program. These are, number 1, the water bottle test, which you can see being performed here, before and after. We are observing the positions of the spine, hips, knees, ankles, and this gives us information relating to whether they are powering movement through the posterior kinetic chain or knee loading and anterior chain dominant. The second test is a simple sit to stand and requires the patient to sit on a 24-inch chair and then stand up again. This different stimulus will drive either a correct or corrupted motor pattern manifesting in functional or dysfunctional movement. We have also investigated digital analysis of movement at the beginning and at the end of the NeuroHAB program, utilising Dorsa V wearable movement sensor technology. All patients fail these primary tests at the beginning of NeuroHAB movement therapy. The transformation is phenomenal toward the end of the program. The grey, black and red movement traces are completely different at the beginning of the program compared to completion. The grey and red trace represent trunk and pelvic tilt, or flexion from vertical, and the black trace is an extrapolation of the relative difference between the flexion movement. More proficient movement of the spine reveals a minimally displaced black trace, reflecting maintenance of neutral spine and hip-centric rotation, with very similar degrees of pelvic and trunk flexion. An indispensable tool integrated into every class is the $4 broomstick. It serves as an aid for patients to learn about the neutral spine position. We want 3 points of contact with the occiput, interscapular region and the sacrum. This is maintained as patients go about other drills to coordinate posterior kinetic chain activation, hip-centric rotation and unloaded knee positions. The hip hinge remains the foundational movement to learn NeuroHAB. Performed correctly, it exemplifies NeuroHAB proficiency regardless of range of motion and power, such that any patient who does not have a true MOB can perform it and progress from there. It can take some patients the better part of 4 to 6 weeks to become confident with this movement and express it as their default bending movement, as opposed to a corrupted motor pattern, knee-loaded movement. We make a conscious effort to scrutinise every patient when they are not aware we are observing them, such as when they bend forward at the drinking fountain or go to pick up their bag at the end of class. Often patients displaying the skillful movement during class falter when they are performing simple tasks with movement dysfunction creeping back. This is a very opportunistic moment to highlight that every second of every day should be seized upon as a rehab opportunity.
That's better, yeah. So,
once motor patterns correctly initiate posterior kinetic chain powered proficient movement, we can progress to sit to stand and squatting. Initially, the range of motion has to be significantly modified because soft tissues simply are not conditioned to enable sitting in a normal chair with the correct technique. So we elevate boxes during drills. We also encourage this at home too. As movement proficiency is maintained with necessary range of motion restrictions, soft tissue steadily becomes stronger and healthier, and protective hypertonia subsides, affording a reversal of the sensation of tightness that never settled despite years of stretching and deep tissue release. Patients are in awe of their restored range of motion. We can then remove the height restrictions in a progressive manner and continue the process, repeatedly reinforcing NeuroHAB movement proficiency, integrating more loads, extending range of motion, and challenging movement tasks like adopting wall balls, deadlifts, kettlebell swings, ring rows, rowing, and eventually intense Olympic weightlifting. Not for the purpose of building strength or fitness, but for the purpose of challenging the nervous system to acquire skillful, coordinated motor patterns, manifesting in moving proficiency for everyday life activities. Eventually, relative intensity becomes a significant experience for all patients, regardless of age, from teenagers to nonagenarians. The oldest patient we've had is 91. Intensity is actively sought for the health benefits of multiple neuroendocrine hormonal responses, endorphin release, type 2 muscle fibre stimulation, and neurophysiological and musculoskeletal favourable adaptations. In summary, this means your body and everybody is curing movement dysfunction, regaining functional capacity, and reversing the root cause of back pain symptoms definitively. Simple, effective, affordable, safe, and this equates to good medicine. Thank you all for listening, and to my team for their commitment to guiding our most challenging patients back to health. We are honoured and privileged to be entrusted with the health of our patients and take accountability for outcomes. We appreciate your belief in us when we say that this post from leading researchers in Australia is a load of nonsense. Thanks very much.